Steve Mosley and Chris Joseph, also from Volpara. We're going to introduce you today to a couple gentlemen, Robert Pizzatello, medical physicist, Robin Shermis from Toledo Hospital, to talk about, can't hear? Got to pump up the volume? Is that better? All right, that sounds good. So again, thank you for coming. We're going to start off today with Bob Pizzatello, kind of get some information on X-ray dose and mammography, and then roll into Dr. Shermis to introduce how we use the product in his site in Toledo, Ohio. Thanks.
Welcome, folks. Welcome. My name is Bob Pizzatello, and what we're going to talk about today is something that maybe we haven't thought about very much, but let me start by asking a question. How many in the room have ever been asked a question by a patient, what's my dose? Have you ever been asked this question, what's my dose? Yeah, right. So a lot of those questions, they usually say, find the physicist and let the physicist answer. And sometimes we do that. But to be honest, we really have to wave our hands when we talk about what is the dose to you as an individual patient. So what I'm going to talk about for the next 15 minutes is to help you understand why that has been the case in the past and why it's changing now due to some capability that we never really had before, which is to know what the breast density is. So that's in a nutshell what I'm going to talk about for the first part, and then Robin will talk about some other clinical applications. In general, in my experience, patients all across the country are more interested in what dose is. There are continuing articles in the paper. I'm sure you've seen them. Remember the New York Times, there were 13 articles that Walt Bogdanich put together. And then just a few months ago, there was an op-ed piece written by Rebecca Smith-Midman and another physician saying, are we giving ourselves cancer? These are the sorts of things that get people concerned about radiation dose, and it's been going on for the last several years. So we know that people are asking more questions about radiation dose. I believe that we as a profession have an opportunity to sort of grab the bull by the horns and to say, here's what we understand about dose so that when patients ask us questions, we can give them reasonable answers. And part of the job of a medical physicist, in fact, the primary job, is we're sort of the guardians of image quality and dose. So that we work, of course, closely with our radiologists so that together with the technologists who are doing the exam, the team works best to give the patients the care they need. But we know that radiologists rely on the medical physicists to be the watchdogs of dose. I also do a lot of work in CT. There's been a lot of interest in CT in recent years, and what we have found is that there's more interest in knowing what the CT dose was. So if you've ever read an article in just about any journal in the past 5 years, somebody will have said, the patient dose from this procedure was 25 milligray CTDI. CTDI is not a patient dose. It's the dose to a cylindrical acrylic phantom that's either 16 centimeters or 32 centimeters in diameter. It's not the patient dose. And as we've become more aware of this, particularly in the CT world, we've started to say, well, what is the patient dose? What are the organ doses? What are the doses that we're giving to individual patients? Because if we don't know what those doses are, we can't possibly optimize. So these companies here, Radiometrics and DoseTrack and Dose Monitor and Dose Watch, and of course the ACR Dose Index Registry, are all capabilities now where through software solutions we can look at what patient doses are in CT. And there's a great deal of interest, so much so that the Joint Commission, which as you know accredits more than 80% of the hospitals in this country, the Joint Commission published new requirements that are effective July 1st that require for CT a lot of dose measurements and comparisons with benchmarks and dose protocol committees, all really good things. So all these things I see in the CT world are coming together to put more of a focus on dose. I think the same thing is likely to happen in mammography. We also know that our patients have scary images of radiation dose. So on the plane coming over, I've told this story since I had dark long hair. That's how long I've told this story. But on the plane coming over last night, can you believe that there's another remake of Spider-Man? They only just had a Spider-Man a couple of years ago. But in the new remake, as the old, he was bitten by a radioactive spider. So people in the public have this general fear of radiation, and what we want to do is we want to counter it with some confidence and knowledge about what we know and honesty about what we don't know. So for example, at the ACR AMCLC meeting a couple of weeks ago, a number of us were invited to come and record some new segments for the Radiology Info website, and I was asked to sort of look into the camera and say, I'm talking to a patient, help them understand what dose is and what the benefits are and how the benefits outweigh the risk. So there's a lot of interest in helping to communicate what patient doses are. I'll tell you that there's a practice out in Long Island that started handing out dose cards to patients that had CT scans. Now this was a real problem because they gave to an individual patient a card, but it's not their individual dose. It was that dose to the cylindrical phantom plus a bunch of other things that aren't right. So we definitely want to do the right thing and not the wrong thing. And if you do a quick Google search for X-ray dose, there's 40 million hits on Google. So there's a lot of things being written about dose. We know that the radiation dose to the breast is relatively low. And again, for those of us that have been around a long time, a real long time, we remember zero mammography and non-dedicated units, and then moving to the dedicated units and the molybdenum targets and so on. And the younger people in the audience are thinking, yeah, I wasn't even born then. But we've made great strides in lowering the dose to the breast, but it's all been based upon some measure of the dose that really is not a person's dose. It's based upon the dose to a phantom. So if we were able to get accurate dose measurements, now in the world of everything being digital, it's really simple. The more dose, the prettier the image. And we've got to try to always balance what's the right dose so that you can achieve the diagnostic confidence that you need, but no more dose than that, because we don't need to give anybody dose that's not necessary. So the International Commission on Radiation Protection looks at all the data on radiation injuries and cancers that have been developed going back from Hiroshima and Nagasaki, and they publish tissue weighting factors, which give you an idea of the relative radiosensitivity of different organs. And this is so that we can make some estimate of what the risk to a patient is like who has only had dose to part of their body, given that the majority of the data that we have are from Hiroshima and Nagasaki survivors who got dose to their whole bodies, right? So this is that effective dose concept that maybe you remember some physicists taught you, and maybe you got the question right on your boards years ago. But the idea is that we have these weighting factors, and their weighting factors for the breast is 0.12. It's actually more now than the gonads. These numbers changed in 2007. Mean glandular dose is widely accepted to be the metric that we use. And let me just say one other thing that's really important about mammography, which we all know, it's the only exam that we now do in big numbers on healthy patients. So we want to be especially sensitive to making sure that we're optimizing our radiation dose. So, do you know how the dose is calculated on your machines? Does anybody really know? I have to tell you that I was not all that knowledgeable several years ago until this sort of came to the forefront. I'll tell you that years ago, when I was working with many, many clients, I started calculating doses to patients who had different sizes of breasts. And then my clients got very nervous. They said, well, these numbers are more than 300 millirad. I said, well, yeah, a bigger patient is going to need more dose. But that is not something that's all that much in the forefront. Everybody thinks about the 3 milligray, 300 millirad, which is a limit that FDA now has, but it's for that ACR plastic phantom. It's not for a human being. So when you look at the numbers that are available to you as a radiologist or a technologist, and the numbers that come up on the screen, what you find is that there is an average glandular dose or a mean glandular dose that is reported, but different manufacturers use different methods to calculate those numbers, and they're not the same. And that makes it complicated. It's more complicated because since it's printed on each image, it's associated with each patient, you get the feeling that that is actually the dose to this particular patient, Mary Wilson. But it's really the dose to Mary Wilson if she were a 4.5 centimeter acrylic phantom that was 50% glandular. So it's really not Mary Wilson's dose. There are many different models that have been proposed, and they're all good models, but they all require that in order to calculate the average glandular dose, you have to know what the percent of glandularity is. And that is an estimate that different manufacturers use different percentage numbers. So that's really one of the big factors here. The way we calculate average glandular dose as medical physicists, we follow the procedure that's long been established by the ACR since about 1987, as I remember. That's when I first got started doing this. We use that acrylic phantom that's 4.5 centimeters, 50% glandular, 50% fat. We look and see what technique your machine used to get a good image there, and then we make a measurement of how much radiation it took to get that, and we apply a bunch of correction factors based on a 50% glandularity. However, we also now know that 50% glandularity is probably not realistic for the population. So there's an article that Martin Yaffe and his team published, I think it was in '09, The Myth of the 50-50 Breast. When you start to do quantitative measurements of breast glandularity, you find that that's really not common at all. So how do we determine dose? I love this slide because this tells you that medical physicists are really smart, because this is complicated, right? But basically we make a bunch of measurements on machines, and then we have to look up some data in tables. But what's really important is that we have to estimate what that breast density percentage is so that we can look up the right value in the table. And in the absence of that, you have to just take a guess. So Dave and I have been friends for a long time. We actually live nearby each other. And when he first told me about breast dose for the individual patient, he said, "What do you think?" I said, "Well, the problem with that is you have to know the breast density." And all of a sudden the light went on. That's what Volpara is able to do now. So we're able to do something that we could never really do before. So when you look, and here's an example of a screenshot from one of the workstations, and it shows for a specific patient a number of factors. It says what the entrance dose is and what the organ dose is. Presumably that's the average glandular dose, but you don't really know how that was calculated, and it most likely does not really represent that patient's dose because it's assuming the same percentage glandularity for every patient that machine calculates. And that's not accurate. What we have found is we've done some studies to actually calculate what the real average glandular dose is, compare it what the machine reports, and we found differences up to 40%. So that's pretty important. If you're going to be giving a patient an estimate of dose, and I believe patients are going to start to ask more and more for these questions, we'd like to give them a number that's accurate. Here's another example from one of our clients. This is the same patient, imaged 3 times over a period of 2 years. And what you can see is that the average glandular dose that is reported varies from 0.8 milligray to 1.5 to 2.3 milligray. Well, the breast didn't change that much, but what happened was she was imaged on 3 different machines. This is a large practice with many different types of machines, so the assumptions used to calculate the average glandular dose, the breast density assumptions, were different. Well, if you were a patient and you happen to, and some patients do this, my sister is one, she wants to know all these numbers, she writes them down, she could easily say, well, why was my last exam more than double my first exam? Why did I get all that extra dose? She didn't get any extra dose, but the calculation's not that accurate. So we'd like to avoid that problem. We have the exact same problem in CT. There was a great article that Tony Seibert published in JACR 2 months ago talking about how a patient who had a CT scan, a pediatric patient, 2 scans, 2 weeks apart, 2 different machines, the dose reported was dramatically different. And the mom was very concerned. Well, it was 2 machines that used 2 different algorithms. So the whole issue of being accurate about patient dose is really coming more to the forefront. So what do we have to have in order to actually calculate a patient patient-specific average glandular dose? Well, you need 4 things. First, you have to have some a priori knowledge of the radiation that's incident on the patient. So we call that the entrance air kerma and the half-value layer. Well, these are the kinds of things that medical physicists do all the time. We're required to do it annually. At some places we do it even more often than that. That data is absolutely available. The second thing you have to have is the technique parameters that were used to create the image. And of course, that's easy because that's all in the DICOM header. The third is we need some tools to convert air kerma to average glandular dose. So there are a number of different models, and the dance model is one that allows us to utilize the actual glandularity of an individual patient. And in order to get that glandularity, we have the ability to use the VolparaDensity, which tells us what the volumetric breast density is, so that we can roll these things together and actually understand what the patient's dose is. So we can now do patient-specific average glandular dose. So this slide shows you an example of how we have compared. This is where the displayed dose equaled the dose that was calculated by some of my colleagues using the Volpara method. And what you see is that the displayed dose is lower than the actual dose for the less dense, and then for the more dense breasts, look at that. They line up very closely. So that tells us that for this particular machine that we used in this study, these maybe 100 patients or so, that was the algorithm that this manufacturer used. So they were assuming a high breast density when they calculated the average glandular dose. But it varies depending upon which machine you have. So what we can say then is if we look at the Volpara breast density and the dose, the output can look like this. So we've got the relative density scale here. So this is a scale D under the new terminology. And we're able to calculate what the individual patient's dose was. And then you can also show what the pressure was. And that's the actual breast density here, 18.7%. So we're now able to do something that we've not been able to do before. So what does all this mean? In the digital world, we are able to optimize. And in the CT side of things, we now have put together CT protocol review committees, and we're trying to optimize the techniques for each type of study that we do, the protocol parameters, so that we can get the right image quality at the lowest dose that the radiologist is comfortable with. And we do this on facility by facility basis. We have to know what the real dose is in order to optimize for that. So how many of you know about these Fitbit things? So I've been wearing a Fitbit. Do you like your Fitbit? Yeah, I love it too. So I've had mine for about 1.5 years. Okay, so I haven't lost any weight, but I've walked a lot. I walked, what did they say? 1,000 miles in the last year. So that's not bad. But if I didn't have the Fitbit, I would never know if I was reaching a target. I wouldn't know where I was trying to go. So the same principle I see applies to mammography. If we could start to get to a world where we really know what the doses are to individual patients, then first of all, when patients ask the question, we can give them an accurate dose, an accurate answer to say, this is what your dose is. And second, as we start to try to refine the technology of imaging, what kind of doses do we really need? We'll be able to use the accurate benchmark of what the real patient-specific breast dose is, not the dose to a phantom. So I think these are really exciting times. I'm personally very interested into seeing where this can go. I'm working closely with Volpara to see how medical physicists can upload our measured data into a database, so because all physicists have to measure these things, so we can get really accurate measurements of the output of the machine and hopefully have a much more accurate representation of the patient dose. So that's the end of my portion of the talk, and we're going to do questions afterwards, right, Dave? Thank you very much.